Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Til Luchau.
Welcome to the Thinking Practitioner.
Books of Discovery has been a part of massage therapy education for 20 years. Thousands of schools around the world teach with their textbooks, e-textbooks, and digital resources. In these trying times, this beloved publisher is dedicated to helping educators with online-friendly digital resources that make instruction easier and more effective in the classroom or virtually.
Books of Discovery likes to say learning adventures start here, and they see that same spirit here on the Thinking Practitioner Podcast. And they're proud to support our work, knowing we share the mission to bring the massage and bodywork community enlivening content that advances our profession. So do be sure to check out their collection of e-textbooks and digital learning resources for pathology, kinesiology, anatomy, and physiology at booksofdiscovery.com, where Thinking Practitioner listeners can save 15% by entering Thinking at checkout. All right. Thank you again, Books of Discovery. And good day, Mr. Luchau. Good to see you again. It's been, we've been sort of off track for a while here doing some solo things. I did some and you did some.
It's been a while since we've been together on the mic, Whitney. Good to see you.
I missed you. Indeed.
Oh, nice. Likewise. I've been looking forward to this conversation today.
Yeah.
A lot.
All right, good. What is the conversation today?
I wanted your ideas and just to mull over my ideas about sciatica, sciatic pain.
Aha.
Yeah. It's it's one of our most popular courses in my series, and I'm teaching a live stream one day, which I'll go ahead and put a plug in for. That's August 12th, 2022, or you can get it later by recording. And like our other sponsors, you can save 15% if you enter Thinking at checkout. If you want to go look at that on our site, advancedtrainings.com. We'll put that in the show notes. But enough of that advertisement.
Not quite enough. Tell me more about this course. So what are you doing on the live stream? This is, you are doing this as a broadcast for people all over, right?
Yeah, it's basically, I'm going to be in Portland, Oregon, teaching a one-day hands-on workshop, complete with lectures and everything. And then we just have a couple of Zoom feeds where people can see different angles of the demonstrations I'm giving. And there will be actually people that are practicing on Zoom, and we'll be giving them feedback. So we're teaching both Zoom and in person simultaneously. Awesome. We did that. Yeah, we did that last year for a class, and it was really fun. We had people from all over the world, and it's not the same as being there in person, but it was surprisingly effective and satisfying too.
Second best. Yeah.
That's right.
To be there with everybody. So yeah. All right. That sounds cool.
Yeah. And then I should also mention that we do have a handout for our conversation today. I got a couple things I'm going to put in there. You said you had some stuff. Yeah. And we'll pull it together after we record and get it up there on our website. So we can go download that free PDF if you want.
Sounds great. Sounds like a plan.
So anyway, what is sciatica, Whitney?
Well, this is a good question, because certainly if you look at any of the stuff that's been written about it, this is one of the places where there starts to be confusion. This is, just to put one other plug while we're talking about terminology issues here. Are you aware? Well, actually, you and I talked about this. Did you see any of the stuff that came out of the recent International Consortium of Manual Therapists event? They had a virtual event. Was going to be live.
Remember,
they went to
I remember the event. Yeah. What came out of it? What
one of the big things that came out of that was a discussion about terminology, about the need for consistent terminology across manual therapy professions. And that's just something that is great to see some work being done on this and some things to move stuff in certain directions, because this is a perfect example of when you have a term that is not agreed upon and is not accurately defined, it's open to all kinds of different interpretations by different people. And the term sciatica gets bandied about quite a bit, especially as a layperson's term for describing any kind of pain down the lower extremity. And that really isn't accurate. I mean, ideally, we would like to let the term be defined by, pain in the sciatic nerve distribution that is specifically deriving from sciatic nerve involvement. And so that's one of the more
Okay, good. We're going to have stuff to talk about. This is good.
Yeah.
Yes. Okay. So how would you define it? Is that how you define it? Pain in the sciatic nerve distribution
I would say,
area
pain
arising?
in the sciatic nerve distribution that is derived specifically from sciatic nerve involvement, because you can have pain in the sciatic nerve distribution that's not from the sciatic nerve. So,
all right. So that opens up the debate about the derivation of pain. What is the cause?
Well, yeah. Mm-hmm.
But you're saying, okay, so where is the sciatic nerve distribution area?
Yeah, so this is going to be, a wide area all the way from the lumbar, depending on which branches we're talking about. But this could be from the lumbar region through the gluteal area, and of course down the back side of the leg and all the way into the foot, depending on which, different nerve branch that we're talking about and where it branches off of there. But in general, we're talking pain down the back side of the thigh, gluteal region, and down the back side of the thigh into the foot.
Gluteal region, otherwise known as the butt.
Yeah. Yeah.
And maybe some low back. Is that in there at all?
Yeah, certainly.
Okay.
Most certainly. Yeah. Yeah.
All right. So pain in the butt and back and leg. And that's, this is we're getting technical. We're already getting to the weeds, which is really cool. But I just want to say this topic, for nomenclature reasons, but also for other philosophical reasons, is really an interesting poster child of a condition, because there are some amazing things we can do to help. And yet there's times that it's not how we think we might help too.
Mm-hmm. And you're going to explore that with us a little bit, right?
We are going to, I'm going to explore that with you, and I'm going to ask you about it too. But there's, people come and it hurts and they just want it to stop. And often we can. And even when we can't, there's amazing things we can do.
Yeah.
But anyway, you're saying it's pain in this region.
Yeah.
You're tying it to the sciatic nerve itself. Okay.
Yeah. And, there are people who say, I've got sciatica, and basically they have, pain either in their butt or down their leg. And so I'm not going to say, well, no, you don't have sciatica. If it's, pointing to, there may be some other sort of derivation or source of that pain. I would certainly clinically wouldn't negate that experience and just say, well, let's see what we can do with
there. You go. You don't want to argue with them about what they're calling it.
Yeah.
Another way I've heard that talked about is that sciatica or sciatic pain is a symptom. It's not a condition per se, that it's something that shows up as a result of something else going on.
Yeah. I think
and it has become a colloquial term just to mean what you said, pain in the back. But
so I think I may have talked about this in one of our earlier episodes. I'm curious if this has ever happened. I had a situation where I was in clinic work. This was back when I was in Atlanta and working at Emory. And because Emory was a really prominent medical center in Georgia in the South, people would come from especially rural areas where they didn't have access to really good, high quality orthopedic care. So they would come up to Emory. And I had this guy come in one day, and he was complaining about the leader down his leg.
Mm-hmm.
I'm sorry,
what the leader down his leg, right?
The leader, and I'd never heard that term before, and so I had to have him describe that to me. And apparently, this is a colloquial term in certain rural cultures about pain down an extremity. I don't know where the term comes from. Have you ever heard that term before?
I've heard it in fly fishing. You got a leader.
Oh,
but no, I don't know about pain down the leg.
What does it mean in fly fishing?
It's like the thing the hook's tied to, that last little bit of line there.
Yeah.
If I know my terms.
I wonder if that has any relationship for how this came about or was derived. But
okay.
Anyway, I had to ask for clarification about that. I'm going to have to get, a little clearer on what this is. I've never heard this before. But
well, maybe there's something educational we can extract from that. It is important to ask people what they're actually experiencing and not just take their terms at face value and think that we know what they mean.
Yeah, certainly.
Really
because
dial down their experience.
Yeah, and people might be using those terms different ways for different things. So always good for clarification purposes. So
okay. So what else do you want to say about definition?
Well, so again, just as a reminder, a brief anatomy reminder, that the sciatic nerve is a big sucker. If you ever especially look at some of those dissections of the sciatic nerve, it's about the size of your pinky finger. So that is one big hunk of nerve, comes off of the nerve roots from L4 off the lumbar plexus down all the way down to S3 off of the sacral plexus, and combined fibers all joining together to make up that nerve. And do remember, it has kind of two primary divisions that sort of split usually around the knee. So those fibers can be, sort of blended together and then eventually separating farther down in the lower extremity as well.
So it's a fat nerve. Take a look at you said, I'm going to highlight what you said. Look at your pinky finger. You got a nerve in your backside that's that big around.
Yeah.
And it has some of the longest neurons in the body too.
Absolutely. Yeah. Yeah. So, and, interestingly, as you noted here, when you talk about having some of the longest neurons, a lot of people aren't aware that those individual nerve cells that go all the way down the whole length of those nerves in our extremities are single cells all the way from like nerve root level to the termination of those nerves. So when you talk about the digital plantar nerves in the toes, those nerve cells go all the way up to the lumbar nerve roots. And to me, I think that's just incredibly fascinating.
It is like a 3-foot long nerve in a human.
Yeah.
15-foot long nerve in a giraffe.
Yeah.
Giraffes have a 15-foot long sciatic nerve.
Yeah.
So that means, I'm sorry, I don't mean to steal your thunder at all. Hope I'm not butting in. That means they're vulnerable because they're so long and so big. They're vulnerable to certain processes that smaller, more protected nerves might not be.
And, elaborating on that point, when you mention the length of those nerves, we're not talking just about the length of the nerve as a whole. We're talking about the individual cells, the individual nerve cells in there. And the reason that is so important is nerve cells derive a lot of their function and are responsible for transmitting their own nutrient proteins inside the nerve cell through the flow of something called axoplasm. If that axoplasmic flow is impaired by, let's say, an obstruction or some kind of, thing that's interrupting the smooth pathway of that nerve somewhere along its path.
Something steps on the hose.
Something steps on the hose. Exactly.
It's like a little tube. The nerve is like a little tube with its own axoplasm nourishing the nerve. Yeah.
So once you step on that hose, then everything distal to that point is somewhat nutritionally deficient and therefore potentially sensitized and more vulnerable to other symptoms arising. That's where that whole process comes from, that's referred to as the double or multiple crush phenomenon. So especially when you get these very long nerves, they are highly susceptible to that kind of thing.
Okay. So can I put in a plug for fascia right here?
Absolutely.
Those hoses, those tubes are basically fascially wrapped nerves, or there's a layering system within the nerve that is the endoneurium, epineurium, perineurium, that basically forms that hose-like structure. And so it's subject to all the things other fascia is, which can be healthy perfusion, carrying of vasculature and lymph vessels, including probably lymph flows directly within the tissue. And it can get either scarred or adhered or thick or dense or less perfusible. And that can cause, we're thinking that can cause nerve symptoms too, just the qualitative change in the fascial component of the nerve itself.
Yeah. And we'll expand on this a bit later, but I do want to reiterate that especially some of these things that you're talking about do not show up well on high-tech diagnostic studies like MRI. And so it's very, very difficult to identify those through traditional means. And to me, that's one of the great values of some of the things that we do as soft tissue therapists, is investigating some of these things through much more thorough and comprehensive manual evaluations and looking at these things in functional capacity a lot more than just what shows up on the MRI.
Well, we'll talk about at some point, if I don't talk about it here, we'll put it in the handout, about different sorts of interventions that can leverage that tube-like architecture that can help that hose flow better. Now, you have something in there about true sciatica and the sciatic nerve. What do you mean by that?
I was just referring here. This is basically essentially what we were talking about earlier, which is, true sciatica being something where there is impairment or irritation of the sciatic nerve or its branches being differentiated from the sciatica in air quotes that is just simply pain down the backside of the leg.
Oh, okay.
That might be coming from other causes. So
because I've heard a distinction made between true sciatica and pseudo sciatica.
Yeah, and I would call the pseudo sciatica those things that are not sciatic nerve derived. but
I've heard pseudosciatica referred to piriformis syndrome, et cetera. True sciatica being nerve root, and any other insult or irritation to the sciatic nerve elsewhere along its pathway being pseudosciatica.
Yeah, I've heard that same kind of distinction. I'll have to say personally, I don't like that distinction.
Why?
Because the piriformis involvement, if we're talking about the sciatic nerve, which is the most common way in which the sciatic nerve is, impaired in that region by muscle tissue.
Yeah.
That's impairing the sciatic nerve, as is the nerve root, or an obstruction in the lumbar region.
Yes.
And it seems more relevant to me to make a distinction between those things that are actually impairing the sciatic nerve from those that aren't, and that to me would be pseudosciatica.
That's the distinction you make. Okay,
because it's really hard to make a distinction between. Okay, let's talk about the sciatic nerve is irritated, up here in the lumbar nerve root versus being irritated in the piriformis region. I mean,
absolutely
helpful to do that, but it's still the sciatic nerve. And
it's chiropractors call it type 1 or type 2. Mm-hmm. I've heard it called true or pseudo, but again, the distinction there in those systems that I've heard, different than what you're saying, Whitney, is that it is either nerve root or not, either nerve root or peripherally, more distal down the nerve. Mm-hmm. And again, I'm not even, that's useful for us therapeutically, because we can start to think about where, if there is one location where there might be an issue. But on the other hand, there's limitations to that division as well. Yeah. In my class, I do a distinction between axial and appendicular, but it's often the case that we troubleshoot both. It's hard to tell if it's, exactly where it is, but we can do it empirically. We can do different kinds of movements and things like that to help narrow down, to see what helps, at least, even if we don't know the exact location.
So tell me about that distinction between axial and appendicular. Is that just kind of like what we were talking about here too, in terms of being like in the, torso spinal region versus non or something?
Yeah, axial being nerve root related. Is it the nerve roots of the the feeder nerves that become the sciatic nerve? Is it right there where they exit the spinal canal that they're being either compressed or irritated? Or is it somewhere downstream?
Yeah.
That's axial appendicular. And the only reason I think I keep that distinction is because it does kind of parallel what I understand about the conventional division, but it also helps us, again, start to target where we think we might start. And see what happens.
Right. I think that's a good distinction. I like that, axial versus appendicular. And that does sort of get us thinking too about where we're going to potentially target with other treatment strategies and things like that. So
great. Should we talk about how we would start to narrow that down, how we might recognize what's going on?
We put some notes up here, and I, as we're talking about this, I think what I'd like to do is talk first about some of these other things that might be confused with sciatic nerve involvement, and then we talk about how do we specifically recognize it, because it'll help about when we talk about some of those distinctions.
So differential diagnosis kind of thoughts.
Yeah, I've got like a list of a few things that we know, and this would be sort of in that category of pseudosciatica, of things that can mimic sciatic type pain and produce very similar type of symptoms. So they run the gamut from myofascial trigger points, and especially in the gluteal muscles. We see a lot of those pain referral patterns from especially the hip abductors, gluteus medius and minimus, doing that, and some of the other gluteal muscles also putting that pain down the backside of the leg. And then you mentioned earlier too, piriformis involvement. And this is one that people don't tend to make a strong distinction about, but I've also heard pretty common misconceptions about this when you talk about that whole pseudosciatica thing, and that's involving the potential compression of another branch of nerve off this area called the posterior femoral cutaneous nerve. And I don't know, tell me maybe if you have heard this before. I've certainly heard this numerous times, people saying if you've got pain going all the way down your leg into your foot, then that's a nerve root problem in the sciatic nerve. If you got pain just down to your knee, then that's a piriformis entrapment of the sciatic nerve.
That's what chiropractors are taught.
Yeah.
And there is some good evidence. I think the trend is toward that. If it's below the knee, it's probably nerve root. Bogduk said the opposite. And he was a pretty influential spinal researcher who did a bunch of some of the work we're still using to understand spinal pain. By the way, spinal pain, we're going to talk to Dr. Stuart McGill in an upcoming episode. So I just got to say, anything I say about the back is going to be tentative. He's like Mr. Back Pain.
Yeah. Super excited about that conversation. We'll see how that wraps into what we're talking about here as well. So,
yeah. So basically the takeaway is there's disagreement in different disciplines. Chiropractors will say below the knee, it's nerve root. Others say no, if it's below the knee, it's probably not.
Yeah.
So who knows?
And one of the reasons I wanted to bring that up is that I don't agree with that classification, and I think that comes out of a misunderstanding, I think, of some anatomical factors that may play into this. For example, the posterior femoral cutaneous nerve is, as its name indicates, a cutaneous nerve giving sensation to the posterior thigh, and it terminates around the knee. It doesn't go below the knee. If you compress the sciatic nerve with the piriformis muscle in the gluteal region, you can definitely produce lower extremity symptoms down below the knee. And I think in many of these instances where the piriformis muscle is involved, we're actually entrapping the posterior femoral cutaneous nerve and not the sciatic nerve. And that's why those symptoms only go down to the knee, because that particular nerve. And if you look at an anatomy reference, and maybe we'll put a picture of this in the handout.
We need a picture.
We can see how close that posterior femoral cutaneous nerve is to the sciatic nerve. It's just right next to it. And so it could easily, these structures tend to get compressed against the sacrospinous ligament in the pelvic region. And they're both very susceptible to that. So that's one of the reasons that I'm not quite sold on that whole thing of it's piriformis if it only goes down to the knee. Well, it might be piriformis, but it might not even be the sciatic nerve. You could be looking at PFCN entrapment there as well.
PFCN?
Yeah, posterior femoral cutaneous nerve.
Nice. Yeah. Well, I gotta just ask, how does it matter?
Yeah. So from a treatment perspective, I think that either one of these is going to drive the same treatments as far as I'm concerned, which is primarily we're going to try to target the gluteal and piriformis region. What it tends to do, I think, is sometimes not scare people as much, because when they hear about sciatic problems, that carries a lot of baggage for people sometimes. So, well,
it's pretty commonly associated with disc problems. A lot of people, it's a sign of disc issues, and the classic PTs are taught if you can reproduce sciatic pain, then it means under certain circumstances there's a disc issue.
Yeah,
that thinking is loosening. That correlation in people's mind is loosening culturally. Yeah, but still, sciatic pain, it does sound kind of bad and has lots of associations to people.
Yeah, certainly. And then just a couple other things, sometimes, and again, this is not a real strong correlation, but there have been some indications that irritation of the zygapophyseal or facet joints of the spine can produce radiating pain symptoms in the gluteal and or lower extremity region, as well as can sacroiliac joint dysfunction also produce some of those kinds of symptoms. And the reason I wanted to talk about a couple of these things before we talked about identifying we're making some distinctions about how to identify is that because this is one of the ways in which there's more specific evaluation procedures are helpful to distinguish between true neural involvement and some of these other things that might be joint related or something like that.
Okay, I almost named my dog Zygopophyseal, by the way.
And then you call him Zyg instead of Zen or something.
Something like that. But that basically facet joints, you're saying, can mimic or be similar to the sciatic kind of symptoms, as well as sacroiliac joint dysfunction or sensitivity. Yeah, I should just, while we're doing the list from my side, I should stick in, you mentioned sacrospinous region, but also sacrotuberous related issues, you could say, or at least those are the places we can work that seem to make a difference. Yeah, they're on my map of things to check for sure. Yeah. Well, do you use you more to say about that, Whit?
No, I think those are the ones that I want to bring up as potential confusing identifications that may be mistaken for sciatic nerve involvement. And we did mention, I think, or maybe we didn't mention, in terms of nerve root involvement, there are a couple of things when this is a sciatic involvement at the nerve root level, that this may occur from, intervertebral disc herniations, other types of obstructions, spinal tumors, bone spurs, stenosis. Those are factors. Sometimes, spondylolisthesis or spondylolysis, which there is a breakdown in the articular structure of the vertebra itself. Those are all factors that may also cause nerve root involvement.
So those are all things that can put mechanical pressure on the nerve root where the nerves are exiting the spinal canal.
Yeah. Yeah.
Okay. I should add, before I just ask a different question, there's also some speculation about muscles in that region that run parallel to the nerves, unnamed muscles that have been observed in dissection that seem to be responsible, maybe, so speculatively, for retracting or stabilizing those nerves as they slide in and out of those canals. So if they're muscles, the theory goes maybe they get bigger or get inflamed or something like that. But certainly there's fascial sleeves. There's the dural tube that goes around the nerve, and then the perineurium around the nerve. There's different fascial sleeves there that can also be part of, even if it's not a bony overgrowth or a positional problem that's closing the foramen, there can be soft tissue contents in that foramen that can get bigger, you could say. Either maybe there's muscles in there, maybe not, or fascia. Maybe the fascial can get denser or inflamed or thicker and cause a mechanical compression, stepping on the hose right there, for example.
Yeah.
And then there's a debate about whether you even need compression to have the sciatic nerve symptoms. Peter Sullivan, et cetera, saying that actually it's a question of irritation. And often conventionally we assume that compression equals irritation, but that you can have irritation of the nerve without having compression of the nerve. And that this holds true in surgical interventions where often, or probably manual therapy too, often we'll do something that seems to relieve the direct compression on the nerve, but there's still pain there sometimes, unfortunately.
Yeah. So there's other things that might cause irritation of the nerve other than compression.
Yes.
Examples being like chemical mediators, inflammation.
My favorite. My
favorite thing, right?
My favorite thing.
Yeah.
So it could be local inflammation of some of those connective tissue structures that make up the nerve.
Yeah.
It could be, there's some good evidence for this, neighboring structures like your facet joints, like spinal ligaments and things like that, could be inflamed themselves. And that inflammatory process also irritates its neighbors, just through the direct chemical interaction or immunological interactions with the neighboring structures.
Yeah.
So there are things that, it's a shift in thinking for me too. When I started realizing that sciatic pain was a result of sensitization and maybe not always mechanical compression, that changed my therapeutic approach too.
Yeah.
Because I found this from the beginning. A lot of times I would do things that would clearly help there be movement or more spaciousness or different things there, and the pain would still be there sometimes. Sometimes it would go away magically. Other times it's like we did everything and it still hurts just as much.
Yeah.
So that just made me start to think about pain as an independent variable. Like pain is something different than what's going on either tissue or wise or structural wise.
Yeah.
And there's some interesting, can I tell you a little piece of trivia?
Of course. I love those.
This is I'm looking at my notes here, which turn the page. Let me get there. Okay, yeah. This is from Tom Jessen's story. He says in 1958, Smith and Wright, they published a paper on this. They were spinal surgeons. They wanted to tease apart the sensitivity compression thing. They did disc surgeries and they would sew in pieces of thread looped around the nerves on both sides. Have you heard about this one?
I have not.
So the thread was coming out of the skin. They'd leave it extending out of the incision on both sides. And then afterwards, they would monitor the sensitivity of the nerve and the healing process. So they took away all of the compression of the nerve through the surgical process. They'd leave a little thread attached, looped around the nerve itself. And then every now and then they would very gently tug on these threads to see if the nerve was still sensitive. And they'd use the unaffected side as a control. So the unaffected side wouldn't produce any pain. But in many patients, for days afterwards, the smallest tug on the nerve would still produce the same pain, even though all the compression was gone.
Yeah.
So their takeaway was the nerve is still sensitized, and that's responsible for the pain phenomenon.
Yeah.
But not so much so the hose gets stepped on, but whatever changes in the nerve or changes in the brain around the sensation of the nerve are responsible for the pain.
Yeah.
And that can be independent of the nerve compression itself.
Yeah. And I think this is something we will probably explore in a little bit greater detail when we have that conversation with Stuart McGill here coming up too, because this is certainly his realm. And I've heard him talk a number of times about this in terms of the necessity of teaching people about more optimal movement patterns that really can alleviate a lot of pain. Like, when you have a certain type of thing with your back that causes, sciatic pain, shooting down your leg or whatever, every time you lean over the sink to brush your teeth, and then that just perpetuates into like, I know when I try to lean over to do something else, this is going to hurt. And that whole sensitization thing gets really out of whack. So there's a lot of things that I think, we can play a part in terms of turning that around, but people have to remember this generally doesn't happen quickly. There's, oftentimes going to be a little bit more time involved with making it occur or making it happen. So.
Well, yeah, I can't wait to hear what he says about his, his sniff and his different kinds of things he does to help people stabilize in his model around the nerve. But then for me, teasing it apart from, my goal is to help people with their pain, of course. That's what they want too. But it doesn't always happen right away, even if I've done the tissue part, that there's still a neurological part off and the nerve is still, or the brain is still sensitized.
Yeah.
And that oftentimes that takes a little more time, just time for the body to adjust. And then on the other hand, there's times when that doesn't seem to go away, honestly. As much as confident as I am in my treatments, and as much as I would like to say this is an effective approach, which it is, there's times it just doesn't seem to go away.
Yeah.
And sometimes helping people think about it in terms of sensitivity or irritation more than a compression can be a more helpful reframe.
Yeah.
Can be a way to realize, your nerve sensitized, it's irritated, so it hurts. It may or may not be because it's compressed. We don't really know.
Right. I also wanted to draw back a second to something you said a few moments ago, and highlight this because it's something that I think a lot of people may not be aware of or may not think about a lot. We talk, if you look at the traditional orthopedic literature around sciatic nerve pain, it is strongly, strongly biased towards looking at functional mechanical stresses on nerve roots, discs, and some of those other major structural things. And you've mentioned a few moments ago, and we have sort of learned more in recent years. And I think it is just still grossly underrepresented, the role of a lot of these soft tissues in some of these pain complaints. And especially as we look at, the degree of neural supply from, myofascial tissues in particular into the central nervous system, I still think they have been very underrepresented and underrecognized as contributors to various types of nociceptive overload that people experience. And of course, that's of particular interest to us as manual therapists who work with a lot of soft tissue stuff. But,
totally, just for me.
Yeah.
Either, whether you're thinking fascially or you're thinking neurocentrically and, pain science or fascia science, whichever, or both, there's a whole lot of different ways to help or go after sciatic pain. A lot of different things that aren't necessarily provided in other ways.
Yeah. So
that said, if someone comes to me with severe intractable sciatic pain, or if, there's certain tests we do, like a Lasik test or something that shows pain in certain ways, I want them to be under the care of another primary care physician for sure, but maybe a specialist, either a neurologist or physical therapist, somebody, because to say, there might be some perspectives that I use that are helpful, but that's not to say that I know things that the other people, that they shouldn't come to be getting conventional care as well too. Yeah. That's so important, especially for severe or intractable pain.
Yeah. And that's a very good example. Just, to give another example about that, like, let's say, a person comes in with pretty severe radiating sciatic type symptoms down both lower extremities. And, the practitioner says, well, I think we can, my teacher told me we can do some soft tissue work on this and, help them out a little bit. And so I'll take them on and not refer them or whatever.
Well, that
person needs to be seen by an orthopedist because they may have a central protrusion and a cauda equina syndrome. That's, something's pressing on both sides of or directly on the spinal cord. And that's why you're getting bilateral symptoms. So again, that's another good example of why it is helpful to be able to know some of these things that are big red flags that we do want to send elsewhere.
So both side pain being one of those. Another one is, I'll put it in the handout about the Lasik or straight leg test if we don't talk about it here. But like if someone does that test, they lift their leg and the other side hurts.
Yeah.
That's like a red flag. That's like a go to jail kind of thing. Go to the other practitioner, check this out.
Right.
Something's going on there that's not good.
Yeah. So that's something that's often called the well leg test. And it's fascinating. It's about, it's again helps to have a little bit more understanding of neural dynamics. But, if you do something on the unaffected side and it, increases those symptoms, it's because of the overall neural pull, affecting that side where there is a potential problem. And this usually indicates something that is highly sensitized and probably needs to be seen by somebody else as well.
Mm-hmm.
Doesn't necessarily mean that we can't do some things with people, but they should certainly, I agree with you in that situation. I'm going to refer that person out for additional evaluation as well.
Mm-hmm. Or that's the well leg thing, but I'm talking about, like, say, lifting the affected leg. And the pain starts on the unaffected side.
Oh yeah. Yeah.
So that can be a sign of some spondylolisthesis or some movement in there that's really that needs to be under some serious care there.
Yep. Mm-hmm. Yep. Agreed. So,
okay, what's next?
Well, we want to. Oh, you mentioned a couple things. You mentioned the Lissag test, also called the straight leg raise test. That is probably one of the most common physical examination procedures that's often done for this type of thing. It's, a client is, we'll put this picture on the handout and describe it a little bit. Client supine on the treatment table, and then the leg is raised to see if that increases those sciatic nerve symptoms, because after about 60 degrees of hip flexion with the knee extended, you're pulling on the sciatic nerve and putting some tension on it and pulling potentially the whole neural structures against any protruding or obstructing tissues or obstacles along the path that might, sort of reinforce or reinvigorate those symptoms that the person is experiencing. Mm-hmm. And then we might compare that against some other things that might, for example, isolate the piriformis muscle and its potential involvement. There's a couple different tests for the piriformis involvement as well.
Let's talk about those, but let's go back to you say Lissag, I say Lissig, or the straight leg raise test, super commonly used in orthopedic examinations. Yeah. Really well researched, done with all the different parameters, pretty high degree of both sensitivity and specificity.
Yeah.
And you said pulls on the nerve root. Yeah, it also can pull on the dural tube, for example.
Yeah.
And there's some cool work that David Butler republished in the 90s, of David Butler of the NOE group, pain science group, from Brieg, 78, just showing, Brieg went and sewed little markers onto the sciatic nerve roots and raised the leg. And you could see those markers coming in and out like an inch or more out of the nerve exits.
Yeah.
So you're actually sliding nerves just by lifting the legs, in other words.
Yeah, exactly. And also back to what you said a moment ago too about the whole dural tube involvement, the very last step of that test, involving, head and cervical and head flexion.
Yep.
Pulling the upper end of the whole dural tube and, further sensitizing those maneuvers. And again, David Butler certainly has done some marvelous work on that. Michael Shacklock is another who's done some excellent illustrations of those neurodynamic tests there. So those are very good resources to learn a little bit more about that stuff.
So I use those a lot with clients to help me get a sense, not to tell them whether or not they have this or that, but to help me as a practitioner start to put it together a working hypothesis about where I'll start.
Yeah. Mm-hmm.
If that straight leg raise test shows some sciatic pain, it reproduces their pain, then I am thinking nerve roots. Mm-hmm. If they drop their head forward or they flex their spine, I'm also thinking nerve roots, but probably, like you said, it pulling from above.
Yeah.
If it doesn't reproduce their pain, then I'll go on to the piriformis test that you were starting to talk about.
Yeah. And another thing that I find value in doing some of these procedures is that, for example, if you do that straight leg raise test and you find it highly sensitized, we can use this as a means of saying, look, if you're going to sit down and tie your shoes, bend your knee. Don't do it with your knee out in front of you here, straightened out, because every movement that you do that lights that sciatic nerve up further sensitizes the system. So we can use that as movement coaching for encouraging people to do things that don't irritate those structures further, because now we're zoning in and identifying what are the problematic positions and or movements that really cause them further challenge.
I like it. I might have a little different spin on it. Mm-hmm. I'll tell them to play with the edge of it.
Yeah.
We do want in this model, we do want to light it up a tiny bit. in a controlled way and in a dosed way. So like bend over like you're going to tie your shoes and find the edge of that place that sensation starts, and now back off and now wiggle your toes.
Yeah.
And now breathe. And now, think of a joke or whatever, do something that just helps shift the context around that.
Yeah.
So playing around the edges of the thresholds where that pain starts.
Yeah.
Rather than just like a straight, don't do that, avoid that, which it could be, alarming or make people feel more protective or more fragile over time too.
Yeah. And that's a really good point. I would like to clarify to what, in saying that my encouragement would be to them is that at different stages, different things are going to be appropriate. When it's in the really bad flared up stage, that's where I'm going to tell them, don't do that.
Right.
As they begin to get a little bit more movement, I'm going to do exactly what you said. It's just tell them to push the envelope a little bit, but we don't want to do it when it's really in that flared up stage, because that will a lot of times increase the neural sensitivity.
Well, basic inflammation approaches, meaning if it's inflamed, we treat it carefully.
Yeah.
And this isn't the place, like you say, to stimulate or to increase, willy-nilly, at least the inflammation. We want to calm it. We want to increase the adaptive range around it.
Yeah.
And some of that's through just rest and avoiding, irritants, movements that irritate. And some of that can be recontextualizing or perfusion or hydration, different things like that.
Yeah. And one of the other, I want to talk about for just a second, draw back to our discussion of using these procedures from an evaluation standpoint. I also find these really valuable as a marker of progress for people. So, when you set a baseline at the outset, like they only get their leg up to, about 45 degrees of or less of hip flexion until that really just lights up. And then 6 weeks down the line, we're working, let's take a look at this again and see where we are. And all of a sudden they realize, oh, wow, I can get farther than I did before. That's a nice objective measure of improvement that really stimulates positive thought and positive momentum about making progress in there.
Well, it gives another marker besides just it hurts too.
Yeah.
Because it hurts is hard to track over time. I do everything I can to avoid that being my only measure of success, because it's amazing as we can be about helping people with pain. If that's our only yardstick, it's tough. So things like, can I move more? Can I move before it hurts? Can I move in different ways? In spite of the hurt, all those kinds of things are also great alternatives.
Yeah. Yeah. I love it.
So and that test, you're talking about treatment. There's so many ways you can use that test, raising the straight leg or dropping the head, as a way to therapeutically help the nerve too. I mean, I got a couple in my course from Greg Lehman. He kindly gave me the illustrations about his versions of that. But if you just YouTube like sciatic slider or slump slider or sciatic tensioner, you'll see like dozens of variations. There's people like juggling and doing this exercise. There's people like pedaling a bicycle and doing this exercise. Yeah. Lots of ways to adapt that test into a therapeutic intervention as well.
Yeah. Yeah. So, and you're going to explore some more treatment strategies with us here on some of those things as well. That was just, there's a lot that are based right around that test. Yeah. We can use the sensitivity they find to shift the thresholds, or to hydrate the nerve, or to increase mobility, whatever the goal is. Yeah. But yeah. And there's manual manipulations as well. So I'll put in the handout at least. Is there anything, because I know you're very well immersed in and really well versed in these understandings of neuroinflammation issues. Is there anything that we can do that will lessen, impact, or decrease the neuroinflammation that may be going on from irritated neural structures in this? That's
such a good question. Is there anything we can do to lessen the impact or decrease the bother or the pain of neural inflammation? There is so much we can do. There's not a magic muscle we massage and it all goes away often. Sometimes there is, but there's, I'll put it in the handout. There's like at least 6 different ways to work with neural inflammation. And we've already named or implied a couple of them. One is simply reframing it from being you're damaged to being you're protective. I mean, these aren't damage signals. These are protective signals, for example, helping people think about their pain in different ways. Yeah. It can be that. So that's subtle to there are direct mobilizations we can do that help change perfusion, change the function of that hose in a way that probably helps resolve things immunologically or inflammatorily, where the inflammatory processes get to cycle through and resolve as well.
Mm-hmm. Yeah.
And then like 6 other things in between, or 4 other things in between those 2, whatever.
Nice. Yeah. So, and you'll include that stuff in the in the handout for us. So
I'll put the list of 6 in there, and it'll spur some thinking.
Yeah.
So you mentioned piriformis tests.
Yeah. So there's a few other tests that we can do for the piriformis muscle that are sort of designed to be identifying piriformis syndrome. Again, entrapment of sciatic nerve involvement that might occur in this region. So they primarily target the piriformis muscle. Mm-hmm. Again, this can get into a whole nother can of worms of something that we may well delve into in another discussion some other day. But a lot of people only talk about the
that's
sciatic
never
nerve.
Scared us before. Come on.
A lot of people talk about the sciatic nerve being compressed or irritated by the piriformis muscle, and that is certainly a potential problem. But there's also a number of other muscles in this region that can also be impacted and affected that might show up with some involvement when you do that. There's the superior gluteal nerve, there's the inferior gluteal nerve, the posterior femoral cutaneous that we mentioned earlier, pudendal nerve. Lots of them in there might show up being somewhat symptomatic when you do some of these tests that really kind of zero in on the piriformis muscle, especially the side-lying piriformis test, which is also called the FAIR test sometimes. FAIR is an acronym for flexion, adduction, and internal rotation. And then the seated piriformis test, which sort of contracts the piriformis muscle as opposed to stretching it.
Now, I do one where you pull the knee to the chest and pull it across the midline.
Yeah.
Is that one of those?
That's going to be the pretty much same position as the FAIR test, the flexion, adduction, internal rotation. And, there's some fascinating things about piriformis anatomy and kinesiology that, again, was maybe going down a completely different rabbit hole. But I got stumped by this one day. This was many years ago, and looking at this, because I was like, if you look at that piriformis stretching position, like you mentioned there, that particular position, or the one that's used in the FAIR test, the traditional FAIR or sideline piriformis test, you notice that the piriformis is internally rotated. And oftentimes laterally rotated in that stretching position. You sort of bring that.
The piriformis itself is rotated, or the femur?
The femur is laterally rotated.
Okay, gotcha.
So you bring the femur up in that sort of position, cross it across the body, and sort of laterally rotate the femur. And I got stumped by that one day, thinking like, wait a minute, the piriformis is a lateral rotator of the hip.
Right.
Why are we stretching the piriformis if we put the hip into lateral rotation? That doesn't make any sense. And then a number of years later, stumbled across this, I think in Donald Newman's kinesiology book, a description of the piriformis's action, and noted that it changes action after about 60 degrees of hip flexion because of its attachment point, and becomes an internal rotator, and then therefore stretches in external rotation as you bring that hip up into the position that you're talking about.
Yeah, I can just feel it sitting here talking to you. If I bring my hip up and just do that kind of pigeon kind pose, external rotation, that's clearly stretching my piriformis. But that I never put those two together. That's what is that doing? Stretching that quote lateral rotator, even with lateral rotation.
In lateral rotation, So one of those, a couple of those piriformis tests, like the sideline piriformis test, focuses on stretching the piriformis muscle to see if it is pulling it taut and compressing those nerves. There's another test where you're basically seated and doing a resisted bilateral hip abduction, where you're trying to abduct your hips against resistance from a seated position, and that's like contracting.
With a belt or something, or a band.
Basically, the way we do it is the client is sitting on the edge of the treatment table, and you place your hands on each side of the outside of their knees, and tell them to push their knees away from each other, and you offer resistance to that.
Interesting.
That's called the pace abduction test, and it's basically contracting the piriformis muscle. But sometimes I like or prefer to use some alternative positions for some of these, because you're sitting on your piriformis at that time as well. And so, if you really want to determine
So remove your
make sure,
wallet from your pocket.
yeah, remove your wallet, give it to your therapist, to hold, and they'll decrease the size of the wallet so it's not
Fat wallet syndrome. We know how to reduce that. That's right.
So it's not compressing your piriformis muscle. But that could be done in a supine position too, where you just have them, bring the hips into a flex position and then try to abduct them away from each other. So yeah, those are a couple of variations, but just do remember, and we talked about this in one of our previous episodes about the accuracy of some of these special orthopedic tests, that this is not rocket science. And in particular, I do not advocate people use these tests in isolation without a very detailed history, much more thorough physical examination, very detailed palpatory examination, and all these other things that will contribute valuable information in there.
Well, you're given that disclaimer because they give the illusion of like, oh, I got it. I know what it is now.
Yeah.
And in isolation, we don't. It might be at best a working hypothesis or a place to start.
Mm-hmm.
And they're really fun. I love those tests, but it's their reliability in terms of being able to check out and confirm the diagnosis in other ways is varied. It's super varied.
Yeah.
It's mixed. And it's just great to remember that they're fun for hypotheses, but don't take them literally.
No, and they're, in my experience, this is something I'm going to try to probe probably a little bit more with Stuart McGill when we talk to him, is that I think in many instances those tests are used as a substitute for a detailed and thorough physical examination, and sure. I don't like that. I think that's short-circuiting it, and it's really decreasing the accuracy of what we can potentially do with people. So
it's true. It's so hard to teach the big picture, or especially that to get people interested in the big picture. I mean, if I put an ad out there for a quick test that shows you where to work, that's going to get some results. If I put an ad out there that says detailed clinical examination, long conversation with your client, sign right up, it's going to be a little less.
Learn how to think critically.
There you go. Yeah. Not a big seller.
Zero enrollments for that one.
That's it. You and me, I'll come.
Yeah. Okay. Right. So
anyway, so piriformis, you mentioned some tests that are, probably stretch the piriformis or tension it in ways that if they light up the pain can give us a clue that might be involved.
Yeah.
This one that some people say 30% of people have an alternative pathway for their sciatic nerve.
Yeah. It's something we didn't address at all. And that one, when I learned that, just was quite fascinating, and both just stumped me when you look at those anatomical variations. I think like there's a good bunch of people that have their sciatic nerve going right through the middle of that muscle. Why isn't that thing just screaming in pain all the time? It's pretty amazing.
Yeah. When I learned this, I mean, this is like 1980 something, early 80s, we were learning sciatica was either because of the nerve roots or because of the piriformis. Mm-hmm. And in some people, the piriformis went around the nerve, which it does in a certain number of people, and that caused sciatic pain. Well, you might know this too, but the imaging studies of that situation don't show a higher incidence of sciatic pain in that population.
Yeah, that's right.
So it's not a structural problem. And some people have sciatic pain there, whether it goes through or around or between the nerve, but it's not necessarily a statistical correlation all we have to worry about.
Yeah. And it reminds us, too, that despite the fact of what we see in many anatomy books, there's lots of places throughout the body where nerves go right through the middle of a muscle and don't have pain. And to me, that continues to be sort of mind-boggling, with all the things that we see that produce neural pain from even relatively low levels of compression over a long period of time. The fact that you have so many of these nerves going right through the middle of a muscle that don't produce pain is interesting. So,
well, it just says to me that structure and shape is just one factor in pain and sensitivity, and maybe not always the main factor even.
Yeah, indeed. So what else you got on treatment things here? Well,
I was going to say there are some other places too in the hip, in the glute and posterior glute region where that seems to be helpful to work, and maybe it's because they do cause entrapment, like between the quadratus femoris, that's another place. It's like a little platform there that the sciatic nerve can sit in. And if it seems to be something that can irritate or squeeze perhaps the nerve there. So that's something I think about. It's a little lower down on the femoral shaft than the piriformis attachments per se. And especially, this is one that I just found in my practice because I used to get quite a bit of sciatica. So, working on myself there, getting people to work on me, and then starting to do it on my clients, just working the intermuscular septum in the back of the legs between the hamstrings and the adductors gave me a lot of relief. And conventional thinking would say, well, okay, you're just working on the place it hurts, and maybe the entrapment or irritation is up in the spine. That's probably true sometimes. But there's a Italian paper, and I'll see if I can dig up the reference, that actually found a bunch of entrapments in the back of the leg in people whose pain got better when they addressed those locally.
Yeah.
And that's definitely been my experience, just sometimes just work in the back of the leg where it hurts.
Yeah.
Even if it is sciatic or pseudosciatic or whatever, seems to make quite a bit of difference.
Yeah. There was a paper I came across a number of years ago that found a pretty high correlation between hamstring strains or prior hamstring strains and adverse neural tension in the sciatic nerve, where
there you go.
The healing hamstring strain had scar tissue tethering the nerve and impacting its mobility, and therefore leading to increases in sciatic nerve involvement. And also, just as a note, this is one of the potential causes for recurrent hamstring strains is the fact that you have irritation of that sciatic nerve, possibly after a strain, and scar tissue maybe binding that nerve, preventing its mobility. And then that whole area becomes sensitized, and the hamstrings become even more, hypertonic and potentially prone to stress damage or strain from muscle strain over long periods of time, because they're already hypertonic and overcontracted.
Interesting. Or density of that tendinous area, or the intramuscular septum where the sciatic nerve runs. It runs in a big chunk of fascia right down the middle of the back of your leg. And again, if you have a hamstring strain or something, that scarring could just change the sliding ability of that nerve through that dense connective tissue.
Yeah.
Okay. So do you think, just in terms of things to mention, do you think that the nerve root related sciatica is more common, or sciatica related to somewhere else down the nerve, what I'm calling appendicular nerve? What's your guess or hunch about that?
I'd probably, if I had to guess, I would guess that it's probably more common with other factors other than nerve root involvement. And again, I don't have good data to back that up, but just the very fact that we've got so many other things that may produce that in creating the sort of what you call appendicular sciatic involvement, compared to just nerve root alone. Make me play in that direction, I think.
That's the direction I guess too. I'm still guessing. And I've actually dug into that question, which is more common, appendicular or axial sciatica. And I've found studies that point to both.
Yeah.
I have. For a lot of disciplines, it's assumed that sciatic pain means nerve root, and equate that even with disc involvement.
Yeah.
And there's some studies showing that is a really predominant cause of people's sciatic pain. But there's others that say maybe it's 2 to 1, and the other way, that most 2 times as much peripheral sciatic nerve sensitization as nerve root sensitization. I think in my practice, though, if just the people that I have walking in, have had walking in over the years, my guess is it's a lot more peripheral than axial. Yeah. Maybe if I was in like a spinal clinic or something, it might be different, for example.
Well, I think this also comes back to how is that being evaluated, because I think a lot of the methods of naming this and evaluating this are incomplete, because they're not doing in many instances as thorough of an evaluation investigation. For example, we've known for a long time that disc herniations exist in many people asymptomatically. And so let's say, part of your study group there has sciatic type pain, and they get an imaging study and they find a disc herniation at L4, L5 or something like that. And so make then the jump, okay, then this person has nerve root involvement because they have a herniated disc at that level. But we do know that people can have those disc herniations that don't produce pain. So that's not necessarily the indicator all the time.
At age 50, 80% of us have measurable disc degeneration.
Yeah.
Oh, sorry, not 80% of us, 80% of asymptomatic 50-year-olds.
Yeah.
Just the people that don't have pain, 80% of those have disc degeneration.
Yeah, pretty remarkable. And I think that skews a lot of the statistics of frequency of these kinds of things, because I do think a lot of them have been put in the bucket of nerve root generated pain. And that's also, as we noted too, and Gordon Waddell speaks about this a lot in his book, The Back Pain Revolution, about the dynasty of the disc, and how that led to so many decades of extensive back surgery, which was probably unnecessary for most of those people.
Yeah. Did he come up with that term, do you think? I've heard that talked about.
I think
I even wrote about that a little bit in my book. Yeah, but
I don't know if he kind of coined that term, but that's where I encountered it from him. So, and that age
seems to have passed, but it's still, maybe they estimate 4% of back pain is disc related. That's the more. Yeah. It's still a guess at this point. Yeah. Here's another one. Piriformis syndrome, 6 times more frequent in women than in men.
Oh, no, I didn't know that one.
Yeah. Piriformis syndrome. But lumbar disc issues are twice as common in men than women.
Yeah.
So there's some gender differences there too.
Where we do wonder on rationale for that. That's interesting.
Well, rationale, yeah. It is also occupation related, like truck drivers have 10 times the incidence of disc related pain than general population.
Yeah.
So it might be occupations or activities. Who knows?
Yeah. Yeah. Certainly those long-term compressive loads in certain types of seats and things like that. We probably find that a fair amount in a certain number of the sedentary office workers as well, sitting in poor chairs and things like that, because we know a lot of those positions do increase compressive loads on the lumbar spine inappropriately in many instances.
Yep. That's great. It's most common in people 40 to 60 years of age, meaning after 60, it gets less common.
Oh, you and I are over the hump.
That's right. We're on the improving side of that curve.
Oh, good. One thing's getting better.
Yeah. Experienced by 40% of all people sometime in their life, with up to 5% of the population having sciatic symptoms at any given time. Here's an important point, neuropathic rather than nociceptive, meaning it's, an irritated nerve as opposed to other tissue generating a nociceptive signal. Yeah. That's it. In terms of like the facts, in terms of treatments or things that we talked about, all the different variations of the sliders, those are so useful to hydrate the nerves. The evidence is mixed. There's some good studies that show that a big improvement of people that do sliders, and I'll put one of those in particular, an exercise that was very carefully compared to some other sliders and seemed to have a big higher level of effectiveness. But overall, sliders help some people a lot. Other people, they don't seem to help much.
Can you give us just a brief of definition of sliders for people who aren't aware of what
that straight leg test is a slider. You raise the straight leg and it slides the nerve through the nerve root. And that is thought to maybe hydrate the nerve. Maybe it frees it mechanically, so there's more mobility there. Maybe it changes the sensation, so it normalizes sensitivity in a way. Maybe it had other effects, descending modulation, things like that. But it's something that slides the nerve in the surrounding tissues.
Yeah. Okay.
And then there's variations with the head, with the bent knee, with the ankle, with the angles of the hip, all kinds of things there. With the juggling, the bike riding I mentioned, etc., that basically can get that nerve sliding.
Yeah.
And or tensioning is the other thing that is the Shatlock the dichotomy between the two. Are you tensioning it or are you sliding it? Are you pulling it from both ends or are you pulling one end at a time?
Yeah.
With both ends, like dropping your head and straightening your knee being a tensioner, which can be more aggravating. That's where you were saying like this, let's not push this thing that's hurting.
Yeah.
But like alternating, drop your head as you bend your knee, straighten your knee as you raise your head.
Yeah.
That basically slides that whole nerve track caudally and cranially in a way that can be relieving or calming.
Yeah.
So I'll put those in there, a couple of pictures of that.
And I would just put a plug in here too for why it is helpful to understand some of these facets of neural mechanics, because that may help you choose which one of these approaches you think is going to be most beneficial to somebody. Are they going to, at this stage of their game, benefit more from a tensioner versus a slider, or what's going to be most helpful for them, where they are at this particular point? Because there really isn't a blanket recipe and routine that you say, okay, people with neural problems get this.
That's right. Yeah. Well, this is especially since it's a problem that people experience chronically. It seems to go on for many people over time.
Yeah.
It's also super important to get people to track the results of what they try.
Yeah.
I think of the guy, this is one of you talked about your leader client. This was a guy who rode his Harley to his sessions, and it was a couple sessions before I got him comfortable enough even to take off his rodeo belt. Maybe we need to explain a rodeo belt if you're not in the West here. Mm-hmm. Rodeo belt's like a big fat leather belt with a gigantic belt buckle in front.
About the size of a manhole cover.
That's it. So yeah, forget taking off his blue jeans. He wasn't going to do that. But I got him to take off his boots, take off his rodeo belt at some point, and he had such painful sciatica that it was, quite a challenge to work with. Yeah. I got it calmed down in a great way and sent him home. It did seem to be pretty piriformis related. Mm-hmm. I sent him home with a tennis ball and showed him a couple of moves just to lie on the tennis ball and move his leg around, and it seemed to really help. So he came back a couple times later, flared up because he'd fallen asleep on the tennis ball. It felt so good that he just kind of overdid it. Mm-hmm. And so that's I learned such an important lesson there, that it's all about dosing. It's all about doing a little bit and seeing how it responds.
Yep. Yeah.
And once it's flared up, it's harder. It's harder. You got to give it time. You got to, keep moving a little bit, but you don't want to keep poking the dragon or whatever.
Exactly. It is, Yeah. Poking the bear.
Poking the bear.
Yep. All right. Anything else that we need
I got so much.
Yeah.
I got so much, but I think that we covered the bases there. We covered the main points I want to make, and the rest is just more technical stuff that's easier to see than to talk about. So I'll put a couple of pictures in the handout, and then, maybe people will come to the training too, or check out one of the other things. You mentioned like some understanding neurodynamics. Do you have anything in your repertory classes that?
Yeah, we definitely explore those things in our both our cervical, lumbar, and pelvis classes. All three of those courses, because of the role of these tissues, we explore some of the neurodynamic testing, both from the evaluation and treatment standpoint as well. So, yeah,
great.
Yeah,
we'll put some links in there to your site, etc. But maybe this is a good time for our rollout for our closing sponsor.
Yes, indeed. And who is that today?
Well, in addition to me, since I'm kind of sponsoring this episode with our sciatica.
That's right. Yeah.
Let me do that plug first. The sciatica live stream course, August 12th, 2022, or later by recording if you're listening to this later. Mm-hmm. And if you're a listener to this podcast, which if you've made it this far, you qualify. You can save 15% by entering Thinking at checkout at advanced-trainings.com. Now, our other sponsor, our rollout sponsor, is Handspring. And when I was looking for a publisher for a book I wanted to write, I was fortunate enough to have ended up with two offers, one from a large international media conglomerate and the other from Handspring, which at the time was a small publisher in Scotland run by just 4 people who love great books and who loved our field. To this day, I'm glad I chose to go with Handspring, as not only did they help me to make the books I wanted to share, the Advanced Myofascial Technique series, but their catalog has emerged as one of the leading collections of professional level books written especially for body workers, movement teachers, and all professionals who use movement or touch to help patients achieve wellness.
And Handspring recently joined with Jessica Kingsley Publishers Integrative Health Singing Dragon imprint, where their amazing impact continues. So head on over to their website at handspringpublishing.com to check their list of titles, and be sure to use the code TTP at checkout for a discount. So thanks again so much, Handspring, for continually supporting the Thinking Practitioner podcast. And we do want to say a thank you to all of our sponsors, and of course also to you, the listeners. We appreciate you hanging out with us and hope we've shed some light on some interesting things for you. As a reminder, you can stop by our sites for show notes. And this one, we do have a handout available, and we'll put that at the bottom of the show notes where that handout is available. So that'll be coming off of Til's site, I believe. So thank you for that, Til. You can find other information on our show from our websites. Mine is academyofclinicalmassage.com. And Til, people can find you where?
Advanced-trainings.com. If there are questions or things you want to hear us talk about here, or feedback you have for us, quibbles, complaints, or spontaneous remissions, anything else you want to tell us about, email us at info@thethinkingpractitioner, or look for us on social media just under my name. Our names. My name is Til Luchau. Whitney.
And I will be also found on social media under my name, Whitney Lowe. And if you will, take a moment, if you can, rate us on Apple Podcasts. It does help other people find the show, and that helps encourage us to keep at it here for a while. You can also hear us over on other platforms, Spotify, Stitcher, Google Podcasts, or wherever else you happen to listen. So please do share the word and tell a friend. And thank you again so much for listening, and we will see you again here shortly.